So, good morning, everyone. On behalf of All India Ophthalmology Society, I welcome all of you for the free paper session on comprehensive ophthalmology, part 1. So, which one is topic? You just, is it this? Okay. So, I invite Dr. Manvi Deokrishna for her talk on enhanced patient follow-up in ophthalmology, insight from the SHARP project. You can start, madam.
Every day, we are bombarded with an emotional message in the form of various advertisements, while being a finger click away from a world of technical knowledge. An emotional appeal or technical information. When it comes to patient counseling, which of these fares better? Let us take a look at enhancing patient follow-up in ophthalmology, insights from the SHARP project. Certain conditions in vitreoretina need an emergency treatment, and a delay can result in very dismal outcomes. In the subjective high-risk patient randomization project, we looked at interventions to improve follow-up in high-risk cases by using an emotional appeal or by imparting technical knowledge. We recruited patients who were treatment naive with proliferative diabetic retinopathy scheduled for pan-retinal photocoagulation, those with retinal detachment for surgery, and those with neovascular age-related macular degeneration for anti-VEGF injection. After evaluation by a retinal consultant and diagnosis with these three conditions, the patients were directed to a study coordinator who then administered a consent and randomized them into 3 arms. Patients in the base arm received the regular counseling by the departmental counselor, as is the routine protocol at our institute. Patients in the emotional arm viewed an emotional video which depicted an elderly gentleman who had lost his vision due to delaying care. Following this, they also received the regular base counseling, as is the institutional protocol. Patients in the technical arm viewed a disease-specific technical video. These videos briefly highlighted the pathogenesis of each disease and also explained the modality of treatment in a simple language for patient understanding. Following viewing the technical video, these patients also underwent the usual base counseling. At the end of this session, a questionnaire was administered to gauge their emotional response, and we tracked the next 3 patient visits. This prospective randomized controlled trial was carried out from March 2018 to December 2023 and recruited a total of 2,100 patients who were equally distributed across the 3 arms. This equivalent distribution was seen also across the 3 disease categories, with the maximum number of patients having proliferative diabetic retinopathy. When we look up at the show-up probability, the patients randomized to the emotional arm had a better show-up probability than the base arm. This was maintained across the 3 disease categories, with patients in retinal detachment also having an edge on viewing the technical video. Patients who saw the emotional video experienced more fear, sadness, anxiety, and disgust, while those seeing the technical video experienced more of anger. Every day we are exposed to numerous emotional messages, altering our perceptions and shaping our decisions. We found that an emotional appeal is more potent in improving patient follow-up. In SHARP, we chose to have an emotional video with a negative message, since most vitreoretinal conditions tend to have a guarded visual outcome. These findings are in alignment with previous successes of emotional messages when it comes to preventive behavior for cancer or in addressing environmental issues. Technical information can be pivotal and has shown success in prior various studies, like along with cataract consent administration, comprehending anticoagulant use, or for parents to understand pediatric uveitis. On one hand, the emotional video correctly underscored the gravity of delaying treatment by eliciting fear, sadness, anxiety, and disgust. These feelings brought about the feeling of potential loss of vision from delaying care. The technical video provoked anger, possibly from frustration of not understanding one's disease condition. In conclusion, the sharp study proves that patients who are approached with an emotional appeal are more likely to adhere to in-time patient appointments despite the negative emotions provoked. These interventions transcend ophthalmology, and so these findings can be applied to any field of medicine. Improving follow-up can foster a better healthcare system and be the silver lining that the healthcare requires. Thank you.
Would you like to ask? Thank you so much. Thank you.
Thank you.
Okay.
Thank you so much.
We just, because we are running short of time, so I think we should take the question and answers later on or as and when needed. So next speaker is Tanjum Gonge, effect of formative assessment on academic performance of undergraduates in ophthalmology. Is she there? She's not here. So maintaining optimal oxygen saturation, the key to reduce both severe ROP and disability. Presenter author is Das.
Good morning. History has suggested that restricted use of oxygen in preterm infants can lead to high mortality and disability, whereas liberal use can link to ROP. With the upgradation of our hospital and ICU, the number of patients presented with severe ROP has increased. So this prompted us to review our oxygen therapy as a contributing factor. The purpose of this study is to develop some strategies to maintain optimal oxygen saturation in the babies. So using a structured quality improvement method, that is plan, do, check, and act cycle, we first reviewed the problem, then we tried to find out our fault, then we developed a protocol and tracking tool, then we educate our staff, and last we gathered information to check the efficacy of our strategies. 80 preterm infants in 2022 admitted to our hospital and ICU was reviewed retrospectively. Out of them, 16 developed ROP. Among them, 5 required intrathecal injection and laser therapy, and 2 become blind despite of treatment. Then we carried out our staff evaluation, and we found that most of the staff were unaware that high oxygen concentration and ROP is interrelated. They are not properly oriented to the guideline for titrating FiO2. FiO2 is the fraction of inspired oxygen. When a person breathes in the room air, his FiO2 is 21%, as the atmospheric oxygen content is 21%. But when he takes oxygen from nasal prong, mask, ventilation, his oxygen content FiO2 increases. So when there is low FiO2, our nurses aggressively increase the oxygen supply. This FiO2 should be increased 5 to 10% at a time, but due to the aggressive oxygen supply, there occurs rebound hyperoxia. So this alternating cycle of hypoxia and hyperoxia can cause damage to the vascular tone in the premature limit. We also found that the SpO2 target limit in the monitor was not set properly. The higher limit was set at 98%, which is more than which expected in the newborn. And weaning of newborn to lower FiO2 was not done properly due to heavy workload or forgetfulness. So we found that lack of appropriate knowledge and lack of guideline was the main issue to address. So we developed some strategies to tackle this issue. We prepared the SpO2 target range charts according to Stanson BJ, and we placed this chart in each patient clipboard as a visual reminder. And this chart shows that we also adjusted the alarm limit. We brought back the higher alarm limit from 98 to 95%. We also monitored SpO2 trend, alarm limit, and we did regular audit so that patients are complying to it. So we undertook education of our all new and existing staff, and we also taught them how to wean off or how to boost oxygen support. Then in the year of 2023, we gathered information to check the efficacy. We saw that the decrease in the incidence of ROP and there is no subsequent rise in mortality. So, Sao et al. Shows that maintaining oxygen saturation among 85 to 93% can decrease the rate of ROP. Ford et al. Shows that repeating attack of hypoxia and hyperoxia can damage the vascular tone in immature babies. Uchrich showed that variation of blood oxygen tension can predict ROP. So, in conclusion, severe ROP can be prevented only with maintaining some improvement in the clinical practice, but it needs strong commitment from the doctors and staff. And as an ophthalmologist, we are always giving stress on the ROP screening, but screening can only do early diagnosis and treatment. Screening cannot prevent ROP. So, hope this study will show some light on ROP prevention by maintaining optimal oxygen saturation in newborn baby. Thank you.
Thank you for your presentation.
Thank you,
Now I will invite Dr. Asrik Mukhopadhyay for his presentation on transnasal fixation with novel 10 proline suture in multi-stage correction of blepharophimosis.
Hello. Good morning, everyone. Today I'll be talking about transnasal fixation with novel 10 proline suture in multi-stage correction of blepharophimosis. I am Dr. Asrik Mukhopadhyay, and this work was done under the guidance of Professor Dr. Shalil Kumar Mondal from AIOC Kolkata. And we have no financial interest. Now, as we all know, blepharophimosis syndrome complex is a rare disease with features of epicanthus inversus, telecanthus, lateral ectropion, narrowed horizontal palpebral fissure, and ptosis. It is mostly bilateral and presents as autosomal disease, and various surgical techniques have been described for correction of this disorder, and here we're going to present one such technique. We aim to perform a two-stage correction. In the first stage, telecanthus and epicanthus was corrected by Mustard's double Z plasty and transnasal wire fixation using the novel 10 proline suture. And in the second stage, after 3 months, lateral canthoplasty was done for widening of the horizontal palpebral aperture, and Fox pentagon tarsofrontal sling with silicone tube was done for ptosis correction. This was a prospective interventional case series of 25 patients over a period of 4 years, and all the patients had blepharophimosis syndrome with prominent epicanthus and telecanthus. They underwent a full ophthalmological evaluation before surgery, and informed written consent was taken from the caregivers. Patients included were between ages 5 to 45 years with presence of all the components of blepharophimosis syndrome and moderate to severe ptosis. And the patients excluded were those with vertical squint, poor Bell's phenomenon, Marcus Gunn jaw winking phenomenon, mild ptosis, and previous ptosis surgery, as these may complicate our findings. Preoperatively, we measured the inner canthal distance and horizontal palpebral fissure, and this was followed up for 1 year after surgery, and comparison of the preoperative and postoperative measurements was done, and we made out the intercanthal distance by horizontal palpebral fissure length ratio. This is a table depicting all the individual measurements of each of the 25 patients, and to summarize, of the 25, 16 were females and 9 were males with ages between 8 to 16 years, and all of them had bilateral involvement, thus right eye of each patient was considered. Now we can find that preoperative inner canthal distance was 40.42 millimeter, and it reduced to 32.67 millimeter post-surgery after correction of telecanthus. Similarly, preoperative horizontal palpebral fissure length also improved from 21.89 millimeter to post-operative 28.18 millimeter. The ratio, inner canthal distance to palpebral fissure length ratio, reduced from 1.84 to 1.16, whereas the MRD1 value improved from 1.12 to 3.44 millimeter. This is a video of the surgical procedure. First, skin incision is being shown for the Mustard's double Z plasty for correction of the epicanthus. Following creation of the flaps, a transnasal tunnel is created with a 3.5 gauge manual orthopedic drill, and 10 proline suture is being passed through there for the deep component of the medial canthal tendon for close approximation and correction of the telecanthus. And after proline suture tightening, the skin is closed with 3-0 silk, and this ends the first stage after lateral ectropion correction by flap transfer from upper lid to lower lid. Now after 3 months, we are performing the second stage where lateral canthoplasty is being done for further widening of the horizontal palpebral fissure length, and ptosis is being corrected by Fox pentagon tarsofrontal sling using silicone rod. And after end, we can see there is adequate, acceptable cosmetic and functional outcome. In this study, we were fortunate that all of the patients had good vision with no amblyopia, as they maintained their vision by compensatory chin elevation. And we found out that epicanthus inversus and telecanthus should be corrected in a separate stage before ptosis correction, as the tension created by the respective surgeries are in different vectors and oppose each other. Thus, we corrected the telecanthus and epicanthus in the first stage and the ptosis in the second stage. The newer novel material that we have used is the non-absorbable 1O proline suture, which is used for transnasal wire fixation and causes close approximation of the two medial palpebral ligaments via the intranasal bone tunnel. This suture is thick and non-absorbable, thus guaranteeing long-term tensile strength. It is also easy to introduce in surgical procedure, as it is cost-effective and provides effective traction of the ligaments and better reduction of the intercanthal distance. Other materials like stainless steel wire or titanium are difficult to procure and require special instrumentation. Now, as I have already mentioned, various techniques have already been described in different studies like levator resection, maximal levator resection, Z epicanthoplasty, YV procedure, even plication of the medial palpebral ligaments. Now, Callahan has first introduced the transnasal wiring, and here we have found that various strategies and complicated techniques, as have been described, are effective. Two-stage correction is also effective using the novel 1O proline suture for effective, satisfactory cosmetic and functional outcome. However, this was not without limitations, as 3 patients had unequal correction. Some of them had post-operative hypertrophic scar, and most importantly, since this was a non-comparative study, we could not compare with other modalities of BPS correction. I thank you all for your patient hearing.
Thank you, Doctor.
Thank you.
Because of shortage of time, we will come to the next paper. I'll invite Q. Mondal for his paper, Neutrophil Lymphocyte Ratio and Platelet Lymphocyte Ratio in Retinal Veil Occlusion.
Good morning. Neutrophil lymphocyte ratio and platelet lymphocyte ratio in retinal vein occlusion. It is the second most common retinal vascular disease following diabetic retinopathy. If it is not treated, it may lead to loss of vision due to macular edema and retinal ischemia. It can be subdivided into BRVO and CRVO. There are many risk factors like hypertension, diabetes, hyperlipidemia, etc. Pathogenesis is multifactorial and believed to follow the principle of Virchow's triad, consisting of venous stasis, vessel wall injury, hypercoagulability. Inflammatory process play a critical role in development of macular edema, and neutrophil lymphocyte ratio indicate the balance of neutrophil with lymphocyte, and platelet play a crucial role in the pathogenesis of thrombo-occlusive disease. PLR indicate the balance of platelet with lymphocyte. NLR and PLR calculated from hemogram and emerging hematological inflammatory biomarker indicative of systemic inflammation. Their association with diseases like some cancer, diabetes, cardiovascular diseases, atherosclerosis has been well documented. And currently few studies in the literature have documented in the association of NLR and PLR with RVO, with no studies published from India. This is my research question. Aims of the study is to find possible association of NLR and PLR values in patient diagnosed with RVO as compared to age and sex match control. It is a hospital-based cross-sectional study. Study duration was 18 months. Total sample size was 76, case was 38 and control was 38. This is my inclusion and exclusion criteria. Exclusion criteria was pre-existing documented systemic inflammatory diseases, documented blood dyscrasia, patient currently using OCP, anticoagulant, anti-inflammatory, pre-existing glaucoma and globe injury. Result, mean age in study group was 55.18 years and in control group 55.15 years, and 42.1% was CRVO group and 57.9% was BRVO group. Best corrected visual acuity in study group 48.82 ETDRS letter and in control group 80.66 ETDRS letter. And this is baseline characteristics of study participant. And this is the main study variable NLR. In study group NLR was 2.18 mean, and in control group mean NLR was 1.83. There was in mean group in study group there was much more mean NLR, but this is not statistically significant. And in PLR in study group 1182 and 101 in control group, and it is not statistically significant difference. And this is the laboratory finding of study participant, and between NLR and PLR there was no statistical significant association, but in retinal vein occlusion group NLR and PLR value was higher. And from ROC curve, NLR and PLR are not good indicator to predict retinal vein occlusion. And discussion, the pathogenesis of RVO is complicated and multifactorial. Traditionally, the pathogenesis of RVO has been thought to follow virtue triad, and thrombosis and inflammatory process are central to mechanism underlying retinal vein occlusion. And NLR and PLR serve as valuable inflammatory marker in disease associated with thrombosis and inflammation. And Darson et al. And Atom et al. Showing a significant difference between NLR and PLR in RVO, but Kamral et al. And Pina et al. They showed no statistical significant difference between retinal vein occlusion group and control group. And our study also found NLR and PLR were not significantly different between RVO group and control group. And based on our finding, we recommend that future research in this area explore a broader range of inflammatory marker and risk factor for retinal vein occlusion. And our study did not find a significant association between NLR and PLR and RVO, as RVO remains a sight-threatening condition with significant global impact. Further research is warranted to reveal its complexity and identify more reliable predictive marker to improve its management and outcome. This is my reference. Thank you.
Thank you so much. So our next speaker is Dr. Anamika Paul. Please.
She is speaking on early rehabilitation of modified Cutler beard, novel silicone plate for tarsal plate replacement.
Hello, good morning everyone, judges and fellow delegates. My topic is early rehabilitation of modified Cutler beard novel silicone plate for tarsal plate replacement. Eyelids are the curtains of our eyes, and it is divided into anterior lamina and posterior lamina. This anatomy will be helpful for us further in our surgical procedure. There are various malignant eyelid tumors which are treated by surgery. Classification of size of the defect according to the age of the patient. We are interested in large size defect, so in young patient it is 50% and above, and in old patient it is 60% and above. There are different methods of lid construction. We are interested in large size defects, and here we will talk about only modified Cutler beard surgery. Different materials are used as tarsal plate substitutes, tarsoconjunctival grafts, Achilles tendon, sclera, hard palate mucoperiosteal graft, autogenous auricular cartilage, and here we are talking about silicone plate. The aim of my study is to assess the surgical outcome and efficacy of the early rehabilitation of modified Cutler beard procedure at 2 to 3 weeks with silicone plate as tarsal plate replacement in the repair of 60 to 100% of the eyelid defect. Second aim is to evaluate the long-term recurrence of the malignant tumor, and third aim is to assess the functional and cosmetic outcomes. It is a hospital-based prospective intervention study. Timeline was about 1 year, 6 months. It was conducted in RIO, Medical College, Kolkata. Study population was patient attending OPD in RIO, Kolkata. My sample size was 30. All the upper eyelid tumor with defect of 70 to 100% after removal of the tumor were included. Patients with lymph node involvement, metastasis, lower eyelid involvement, corneal involvement, intraorbital extensions were excluded. We did some preoperative workup. MRD1 was measured, LPS function was measured, palpebral fissure height was measured, percent of lid involvement, preoperative FNAC and incisional biopsy was done, MRI orbit was done. This is the 279 scleral buckle. Yes, it is used for RD surgery. This, we cut the scleral buckle first, and then we fashion it with the help of crescent knife. The fashioning is very important because on the basis of this depends our surgical outcome. The length of the silicone plate should be around 30 millimeters, shape should be elliptical, depicting the shape of the tarsal plate. The material is silicone, thickness should be around 0.5 to 0.75, thickness should be around 6 millimeter, angulation should be 30 degree, and there are multiple full thickness holes present on the silicone plate. The percentage of lid involvement by the tumor, around 13 patients had around 60 to 69% of lid involvement. Our study is incomplete without comparison, preoperative and postoperative. We did preoperative and postoperative comparison of MRD1. Pre-operative MRD1 was -3. Post-operative at 6-month interval, it was around 4. Pre-operative LPS function was around 1 millimeter, and at the end of 6 months post-operative, it was around 13. Pre-operative palpebral fissure height was around 2. At the end of 6 months post-operative, it was around 9. The mean central lid thickness at the end of 1 week post-operative was 7 millimeter, and at the end of 6 months was around 4 millimeter. We can see that there is silicon plate present in the upper eyelid at the end of 6 months in the MRI plate. This is the video showing the large lid mass, which is we are taking a 4 millimeter margin and excising the tumor. Then in the lower eyelid, we are cutting with the help of a radiofrequency knife. A horizontal incision is being made 4 millimeter below the tarsal plate. A vertical incision are made. The anterior and the posterior lamina are being sutured with the help of Vicryl, and the silicon plate is being sutured with the help of Vicryl as well, and it is sandwiched between the anterior and the posterior lamina. And at the end of 2 to 3 weeks, we are dividing the anterior, the upper and the lower eyelid with the help of a radiofrequency knife, and the upper eyelid is being prepared. This is the post-operative outcome of the patient. Advantages of my study are early visual rehabilitation, good levator function, compliance, and economical. Limitations are absence of eyelash. In children, there is a risk of amblyopia, so we do not do it. In monocular patients, we do not do it. A silicon plate provides stability to the cutler beard flap. Early visual rehabilitation, we can see initial lid is thick, but after that we can compare with the opposite eyelid. Novel silicon plate is tissue tested, inert, lightweight. Intrinsic curvature helps to maintain the upper eyelid curvature. These are my references. Thank you.
Asking a question. So in some cases there is necrosis.
So yes, sir, we had necrosis. We had 2 patients who had undergone necrosis. Actually, what happened was the diabetic. One patient was highly diabetic, not during the pre-operative period, during the post-operative period. And in one patient, since we are doing the case for the first time, so various fashioning of the silicon plate was done. We did not, in that patient, we did not fashion the silicon plate properly. That is why there was a eversion of the silicon plate from the anterior lamina.
Thank you.
Thank you, sir.
Okay, thank you. Now we invite Dr. Agrima Bhatia. It's rare but may be hiding there, conjunctival rhinosporidiosis.
A very good afternoon, respected seniors, colleagues, and my fellow delegates. I'm Dr. Agrima, and today I'm presenting a paper titled It's Rare But May Be Hiding There, Conjunctival Rhinosporidiosis. So to introduce, rhinosporidiosis is a rare ocular infection and a chronic granulomatous disease caused by Rhinosporidium siberae, which is a protist and belongs to its independent taxonomical class known as Mesomycetozoa. Meso implying in middle of, myceto implying fungi, and zoea meaning animals. It is endemic in India and Sri Lanka. However, there are cases that have also been reported from North America and Eastern Europe. The most common presentation is a soft polypoidal pedunculated mass affecting mucous membranes of nose, pharynx, and conjunctiva. Scleral ictesia, staphyloma formation, and scleral melt have also been reported in rare cases. So to give the case details, it was a 23-year-old male resident of Kerala, known case of bronchial asthma since the last 10 years, presented with chief complaints of foreign body sensation, itching in the left eye for 2 months, associated with a sticky whitish discharge. No history of fever, skin rash, ocular trauma, or surgery. Non-specific history of something entering his eye while driving. Treatment history, which he had taken in some other hospital, included tab-lisolone 40 mg once a day, eye drops, prednisolone acetate, moxifloxacin, homatropin, nepafenac for the initial 7 days with no relief. On examination, the uncorrected visual acuity in both the eyes was 6/6. Intraocular pressure was 16 millimeters of mercury. Conjunctiva of the affected eye revealed upper tarsal conjunctival congestion and follicles on lid eversion. A 5/4 mm sized flat, pedunculated, highly congested mass with a bumpy surface attached at the inferior border of the tarsal conjunctiva, as can be seen in picture A. The grayish white dots were displayed on the overlying surface, as can be seen in picture B. So our differential diagnosis included conjunctival papilloma, hemangioma, arteriovenous malformation, and pyogenic granuloma. We went ahead for surgical excision. So the lesion was excised, light cautery was done at the base to arrest bleeding under local anesthesia and was sent for histopathological examination. On H&E stain, as can be seen in picture A and B, there was focal ulceration of hypertrophic lining epithelium, multiple sporangia of which few were ruptured, and lying within was the reactive mixed inflammatory cell infiltrate. The advanced stains, PAS and Grockets revealed large thick-walled intact and ruptured sporangia with numerous endospores within. It was then that the diagnostic surprise of rhinosporidiosis was unraveled. We continued the treatment with dapsone 50 mg twice a day. We also sought for ENT and physician opinion to rule out extraocular involvement. MRI brain and orbit was found to be within normal limits. The patient was followed up for 6 months and no recurrence was reported. Eosinophilia was noted in our case. Bronchial asthma could have been a confounder. It although settled significantly from 19 to 2%, possibly attributable to 10 days of dapsone treatment. Ocular recurrences are rare, with a rate of 1% and between 2 and 40% for conjunctiva and lacrimal sac respectively. Risk factors include a traumatized epithelium, which makes the transmission feasible when former comes in contact with contaminated water or soil. Presentation is classical with a peduncular mass associated with bleeding, pruritus, foreign body sensation. So why was the DD of pyogenic granuloma made? Because of the overlying grayish dots. Impacted foreign body could have been the other one, possibly because of epithelialization over a period of time. Hemangioma, because of the pinpoint bleeding on eye rubbing, which was also noticed in our patients 2 days before the surgery. So to look at the grid on the right, it shows all these differential diagnoses which appear to be same but are actually different, including pyogenic granuloma, impacted foreign body, hemangioma, and rhinosporidiosis, respectively. The leading question divulged the use of village swimming pool on multiple occasions during the last 6 months. Probably it was contaminated. What could be the causes of relapse? Incomplete excision of the lesion, seeding of endospores to adjacent sites during surgery, ineffective cauterization, and failure to use dapsone during the post-operative period. To decode the mechanism, it was frequent rubbing of eyes due to chronic pruritus, breach of epithelium, followed by use of contaminated swimming pool, which invited the infection. On histopathological examination, as we have seen, multiple sporangia in various stages of degeneration, and some histological findings, which in literature also cite squamous metaplasia and epithelial hyperplasia. To understand this configuration, the site of the infection may decide the configuration of lesion. Bulbar conjunctiva has a flatter and sessile lesion in view of the pressure exerted by the upper eyelid. In our case, it was arising from the tarsal conjunctiva, but probably owing to the lack of space to grow outward, it may have assumed a flatter configuration. So to conclude, rhinosporidiosis is a rare clinical entity. Diagnosis is primarily based on microscopic features, and it should definitely be borne as a differential in any case of pedunculated mass. Thank you. Thank you, sir.
The next speaker is Atul Kumar Singh. On the changes in the corneal parameters after dilation using serous tomogram. You can.
Good morning, everyone. Today my topic is changes in the corneal parameters after dilation using serous tomogram. So the aim of this study is to find out the commonly used mydriatic eye drop on the corneal parameters in the younger population. So this is basically a cross-sectional studies. We have analyzed 55 young individuals with the age less than 25 years. We have taken the sample size of 55 by calculating the minimum CCT probability 520 micron of cutoff and previous year's number of age-matched report individual reported to our unit with 95% of confidence interval. The exclusion criteria were corneal opacities of any grade, any pupil normality is noticed, post-LASIK candidates, and history of any contact lens wear. Coming to the method, we have done the detailed methodological ophthalmological examination like best corrected visual acuity, color perception was checked, pupil reaction was checked, slit lamp examination was done, and pre-dilatation corneal tomography was performed using serous tomogram. In the serous tomogram, we have used 3 criteria, mainly central corneal thickness, corneal volume, higher aberration at 2 mm zone and 3 mm zone. So this is the printout of corneal tomogram. What we have shown is pre-op is corneal thickness minimum. corneal volume, higher order operation at 2 millimeter, and higher order operation at 3 millimeter zone. After that, mydriatic eye drops were instilled in the eye for 3 times for every 15 minutes, and corneal topography was repeated. So we have included 55 candidates. This is the age group. Age of less than 18 years, three candidates was there. 18 to 24 is 51, and 25 years is actually 25 years 1. So average age of the study participant 20.4 years. This is the pre-op evaluation. Basically, central corneal thickness mean value was 526 micron. Corneal volume is 105 micrometer cube. Higher order operation of 2 millimeter zone is 0.055 millimeter square, and higher order operation at 3 millimeter cube is 0.10. If we compare with the post-mydriatic value, the central corneal thickness was significantly increased, and higher order operation at 2 millimeter zone was increased. So we concluded that the central corneal thickness and higher order operation at 2 millimeter zone is significantly increased in post-mydriasis. The effect of mydriatic on the corneal volume and HOA was not found to be significantly different among the pre and post-term values. So just to show, this is the pre-dilatation central corneal tomograph. The thickness was 552 micron, and post-dilatation is 566 micron. Coming to the discussion part, the creative refractivity surgeries are based on the corneal parameters like corneal thickness, HOA, ACD, which highlights the importance of accurate and optical refractive outcome. Very few studies have undertaken to show the effect of plain tropicamide eye drops on the corneal parameters. These studies did not find any statistically significant difference in the CCT values in the age of 18 to 35 years. Combined phenylephrine eye drops and tropicamide eye drops have been found to raise the CCT values, but phenylephrine alone is not implicated in such corneal thickness alteration. A recent study in the Indian population did show a significant increase in CCT and HOA values after installation of the combined mydriatic eye drops. However, this study range was slightly higher side. It's around 22 to 78 with an age of 44.2 years. Our study is unique in that it is included in the only young population is 17 to 25 years of the age, and we utilize serous topogram to assess, which is based on dual principal Schlimpfung imaging and Placido test. Our study also highlights the importance of measuring HOA 2 millimeter zone, which is significantly increased in the post-dilatation values. So this is the first study in the young Indian population of age less than 25 years. The present study also highlights the importance of measurement of corneal parameters for evaluating a patient for refractive surgery before installing any eye drops. Limitation of my study was small sample size. Pachymetry increase was real or an artifact induced in the cornea by installing eye drop could not be established clearly. We did not study the time period required for this value to come back to the normal. So take-home message is the current study showed that the routine mydriasis leads to a significant increase in various corneal parameters, including corneal pachymetry, spherical aberration, which may influence the outcome of keratofractive surgeries. The ophthalmologist should be aware of these issues and make the adjustment their surgical plan accordingly. Thank you.
So you are saying that when we are putting phenylephrine with tropicamide, then only CCT is increasing?
Only not plain tropicamide, but with phenylephrine.
Yeah. Phenyl with tropicamide.
Yeah.
HO is okay, CCT is okay.
So this is approximately what I've seen is around 15 to 20 micron difference is there, if pre and post. And HO is also increased.
HO is okay?
Yes.
After dilatation it will
yeah,
reduce.
HO is
okay. Well known. Thank you. So I will invite Dr. Vipin Rana for his presentation on central retinal artery occlusion in young adults at high altitude. Is he available? No. And what about that first presenter, Dr. Thojun Gongo is there? Does he care? Absent, no problem. So now I invite Dr. Ladi sir, Jivan Ladi sir, for his presentation. Refractive outcome optimal versus ultrasonic biometry modified with the Ladi method using premium IOL. So.
Dignitaries on the dais and colleagues, comparison of target refraction with optical versus immersion biometry with Ladi method using Barrett Universal 2 formula after phacoemulsification with premium IOLs It's a copyrighted article and there is no financial interest. Aim is to integrate immersion ultrasound A-scan biometry with modern formulae like Barrett Universal 2. Advanced formulae require axial length of optical biometry. There is a need to integrate immersion with advanced formulae. Barrett Universal 2 formula suitable for all axial lengths, that's why used in this study. It's a prospective randomized study approved by ethical committee. Study followed the tenets of Declaration of Helsinki. Informed consent was obtained from all patients. Patients above the age of 40 years ready to come for the follow-up for minimum 6 months were included. All patients having vision-threatening complications or conditions were excluded. Two groups, immersion had 100 patients, optical had 100. Randomization score with statistical analysis was used. Study coordinator revealed the type of biometry. Operating surgeon, optometrists, and counselors were masked. Continuous variables, group differences, normality of distribution, best corrected visual acuity in log-MR, categorical variables, group differences, univariate and multivariate analysis, outcome with beta coefficient 95%, data which is standardized with p-value less than 0.05, statistically significant, and all analysis was done as per protocol. Mandatory parameters of Barrett Universal 2 formula were included, that is axial length, antechamber depth, and keratometry. For optical group, axial length, antechamber depth, and keratometry was taken from the optical machine, while in immersion group, axial length was taken from the ultrasound, while antechamber depth and keratometry was taken from the Schimflug imaging. The Ladi method, 200 micron were added to the immersion ultrasound axial length. Ultrasound cannot go beyond internal limiting membrane, while optical goes up to retinal pigment epithelium. The distance between these two is 200 micron. The study and literature search showed foveal thickness was at 212, while central foveal thickness was 182. So average comes to 200 micron. Both optical and ultrasound parameters were entered into Barrett Universal 2 formula. Study target was kept as a 0, except for the EDOF lens. All the variables, age, gender, pre-op, visual acuity, and Gary-Scott cataract were same in both the groups with no statistical difference. While IOLs were used were various types of IOLs, and they were also equally same in both the groups. Best corrected visual acuity, sphere, cylinder at 1 month, 3 months, and 6 months in both the groups was comparable, and both the groups attained 73% target achieved. The Loeys diagram shows that target was achieved in all the cases except for the extremes of axial length. The difference between the two groups was 0.2 diopters. Exact target refraction was achieved in 73% in both the groups, within 0.5 diopter, 94% in ultrasound and 92% in optical group, but not statistically significant. Spherical equivalent, residual refractive error, almost same, achieving target in both the groups. Ladi method of axial length is effective with Barrett Universal 2 formula. Caution should be maintained at the extremes of axial length. As per the previous studies, optical biometry is more accurate than immersion ultrasound in calculating axial length, and that these values derived from both these machines may not be used interchangeably. Why? This study shows that adding 200 micron gate from the ultrasound machine appears to overcome this problem and provide refractive outcome comparable to the optical biometry. Ladi method of ultrasound derived axial length versus Sepsis optical were not studied. That is a drawback. But in white mature cataract also, sweat procedures may not be useful. Advantage, randomized study, adequate follow-up, relatively good numbers. To the best of our knowledge, there are no studies showing and making ultrasound derived axial length compatible with newer formulas like Barrett Universal 2, Kane, Olson, and the Hill RBS. In conclusion, Ladi method adding 200 micron to the ultrasound axial length and using Barrett Universal 2 formula is comparable to optical biometry. Further studies are required with a large sample size using other formulas for widespread use of this technique. These are our references. Thank you. Yes, sir.
So there is a constant, companies providing a constant for ultrasound and for optical biometer.
Right, sir.
It does not cover in that?
We will not use ultrasound. We will use optical only because we are going to mimic now ultrasound.
Okay.
By adding 0.20, we'll continue to use the optical a constant. So your mic is not.
Okay. So you mean you just add 200 microns, that will be equivalent to the optical one? And
Absolutely.
And then that time you have to take the A constant 118.8.
Correct. The one which is given on a box as an optical one, but you must use Barrett Universal 2 formula or formula like that because they compensate for posterior corneal astigmatism.
Okay.
They use artificial intelligence, so the accuracy is far more.
So this is more informative for those who don't have the optical biometer and want to come to the normal.
Anybody in the world can use, anybody into rural area can use a simple biometric machine costing 3 lakhs and can get equally good results.
Okay. Thank you so much.
Thank you. Yeah, please. Beyond that did not show because time is 5 minutes. So if it is something which is more than 25, we found a difference of 0.20 to 0.30. That was also not significant statistically, but we have to be a little bit more careful. Up to 31, you can say axial length. Beyond 25 to till 31, we got good results, but you have to be a little bit careful.
So, thank you so,
no issue.
Thank you so much. We are running short of time.
Thank
We
you.
just want to compensate for the another session. Thank you, Dr. Ladi, so much. So, so do you want this thing? Okay.
So now I will invite Dr. Prithvi Chandrakant for his presentation, Dream to Reality, a journey of innovative concepts brought to reality through 3D printing. That's better.
Good afternoon, everybody. Good morning, everybody. I'm here to tell about my Dream to Reality project. So it's a journey of my 3D printing. So the dream. So when I was a postgraduate, I had two problem statements which I wanted to solve. So those were, one was the anti-segment imaging without slit lamp and posterior segment without fundus camera. So that's where I came up with two innovative devices, that is anti-segment photography with intraocular lens, where I used a cardboard and an intraocular lens to take images of the anti-segment, and then the posterior segment was done with the plastic bottle. But the problem is it was do it yourself and people wanted a proper product and something ready to use. That's why I had a thing to learn a new skill. So that is where I came into doing a 3D designing and printing. And the best place to learn was YouTube. So I went through a lot of tutorials and learned the master of 3D designing and printing. And then started using this knowledge in Tinkercad. It's an online, the laptop is off.
Power is off.
आप इसको दूसरा चेंज क्यों नहीं कर देते?
So, but what if, so I started learning a new skill. So that was 3D designing and printing. So by this, we could actually make products. So I took a tutorial in YouTube. So a lot of videos are there on how to make and how to use 3D designing and master the skill. And then once that was done, I sorted into online free Tinkercad, where you can actually start designing your own products. So it is as simple as making a cube or a circle and joining it. And this is something which everybody is doing right now, even children. So even a child of a 10-year or a 20-year-old can actually use this, has access, and they do the project. So we can use this for ourselves. And that is where the reality comes, where I use this product, made the product. So one was the ASPE, like you see over here, this is 3D printed, and we could actually put the intraocular lens. And then this is the device, which is very simple. It's a holder device which can be put to the phone. And then these are all the images which could be taken from it without a slit lamp. So there was no slit lamp required to take such good images. So once this was done, then I started taking a red cam. So red cam was a bottle, as I said. So we designed a 3D printed red cam like you see over here. And this was able to take images like these. These are all images taken from the 3D printed red cam. Then we came to another thing called slit scope, where you use an adapter, a 3D printed adapter, to convert the torchlight into a slit thing. And then we attached this with anti-segment photography with intraocular lens to take images as equal to a slit lamp. So without a slit lamp, we could actually take a slit image of the findings in our smartphone. The fourth innovation was the glow port. As a retina surgeon, we always need to keep on and switching on and off our microscope light when we go inside the eyeball or come out. So this was a big problem. So we printed a phosphorus 3D printed material, which could be just fit onto the ports, and then with a little bit of illumination, we can actually see how it is glowing. So once you off the light, it will glow very beautifully, and we can actually see where the ports are, and we can use it to go inside the eye without even owning the microscope light. So this makes the surgery more easier and saves times. And the fifth one was the Reti light. As we know, we need an illumination device, but what if the illumination goes off? If the xenon lamp goes off, then we cannot do the surgery, and we'll have to postpone the surgery or make the patient keep waiting. So what we did was we 3D printed an adapter over here, which emits the LED illumination, and then this was focused on the LED light head. So over here you can see how this was 3D printed, and we fit a LED light, and this can be attached to a power bank, and then you can even use this for your orbit surgeries. You can use it as a spotlight, and then also use this for our retina surgeries, where you can see how beautifully we can get the illumination in our endo illuminator. So these were the 5, this is a video showing the same with the light inside the eye during the surgery. See, these were all the 5 instruments that we designed, and this is not so hard. Everybody can design their own thing, and they can bring their own ideas into life. Thank you.
Thank you, doctor. So very good innovations, and make the glow port for the anterior segment. Now, due to paucity of time, we will shift to another presenter, Dr. Shiv Kumar, FACO training guidance. Yeah.
Good afternoon, everyone. Good afternoon, the judges. So, as we are seeing, FACO training has become a fundamental requirement for most anti-segment surgeons. The task has been taken lightly by some and very seriously by many. So, to get into the details, the options earlier we had were as simple as some of them was directly asked to do a surgery directly on a patient. Some have already tried on animal eyes. Others have tried on tomatoes and cell phones, cell phone tape. So the advanced options are, this is something called as an IC virtual reality enabled device. Other things like help me see augmented reality, where they train perfectly for a SICS, and a 3D visualization system. The more these 3 are the expensive options. The wet labs, our own wet labs, and a wet lab aided by a Kitaro unit from Japan is equally useful. As we will see, the help me see training method has been quite good and is available easily. it has used very augmented reality technology where the realistic tissue feel and behavior is there. In addition, there is also a 3D visualization system which many of you must be aware. It provides enhanced precision and depth perception. It also, the surgical microscope is optimized for utilization. It is a very expensive option as of now. So, medical teaching must at some point use live patients to hone the skills of health professionals. So, the traditional methods involve this method directly. Obligation to provide optimal treatment and to ensure patient safety is very important. The old saying, see one, do one, teach one, still holds good, but it's sometimes risky. So, the challenges are, patients are to be protected whenever possible, and they are not commodities to be used as conveniences of training. So, the best standard for patient care has to be established and maintained, and first, do no harm to patients is important. Using patients as learning instruments is only justified when all approaches to minimize risks have been taken. Simulation allows trainees first encounters with real patients to be at higher technical and clinical proficiencies, and this has been proved scientifically. The challenges of standard patient care and standard for education. Once trainees come out of standard education, they should be very confident to handle patients directly. So standard for evaluation, nowadays most evaluation of clinical skills is very biased and subjective by professionals, because how much level you attained is not clearly established. With the evaluation methods of simulators, the standards were very attitudinal and psychomotor also. They can be exactly evaluated. Error management also is superior. Even with supervision, it is inevitable that trainees cause preventable injuries. In clinical settings, errors must be stopped promptly. In simulation, errors may be allowed to continue, and the trainee is allowed to experience how to deal with a difficulty. So simulators enable sufficient opportunities for practice, exposure to infrequent yet critical scenarios. Some of the trainees may have critical steps which are difficult to learn. So each student can be customized and proper training can be done. Standardization also is easy. Patient variability is expected. Feedback and instructional controls are very modifiable. So the powerful motivators to use stimulators are the lower cost and better access to symptoms and reduced training time and reduced errors. So conclusions, before joining a formal course, most students must use some methods of training in their own offices, in their own practice, before they actually train a formal course. During the formal course, it is essential to take care of the patients. If they are training in the same city as they are going to practice, better to follow the actual patients whom they have operated on and maintain a list. And after the course, the lifelong learning should continue. So to conclude, just thank you very much.
Thank you very much, Dr. It's very important to get the FECO training. So he has given the very points how to get the FECO training. Now, thank you so much. So our next speaker is Kavita Ramakrishnan, a synopsis on dilophilaresis.
Yeah, good afternoon, everyone. This is a talk on underdiagnosed ocular dirofilariasis, a synopsis. So dirofilariasis is one of the zoonotic filial infections which inadvertently affects the human beings. It is caused by filial nematodes. So dogs, cats, and some carnivores are hosts. Humans are accidental dead-end hosts. Infection is transmitted by mosquito bites. Common species of dirofilariasis are D. imitus, D. repens, and D. tenuis. D. imitus, also known as heartworm. So D. repens causes a subcutaneous lump in face and conjunctiva, and ocular involvement is usually periorbital, orbital, subconjunctival. D. imitus infection is associated with human pulmonary dirofilariasis, usually asymptomatic. So we included 12 cases of retrospectively proven ocular dirofilariasis. In all these cases, recovery of worm was done, which was sent for microbiological examination and species identification. Conjunctival worm was diagnosed preoperatively in slit lamp examination, and imaging was available in all our 7 cases of adnexal worm. So conjunctival diaphylaris is often misdiagnosed as allergic conjunctivitis. So here you could see, sometimes you could see it just as a cyst, and sometimes you could see the tightly coiled diaphylar worm. So careful examination is always important. UPM images of conjunctival worm showed a subconjunctival cyst with hyperechoic areas without scleral involvement. So this is a video of retrieval of the conjunctival worm. So a small nick is made after for this, and you have to hold the worm and pull it at one stretch, at one go. So this is a thin worm, so this is how it looks. So it has to be pulled immediately, otherwise it goes back into the subconjunctival space. As far as orbital or eyelid diaphylaris is concerned, patients may present with palpable mass with well-demarcated boundaries. High index of suspicion is needed for such cases. The diagnosis of diaphylaris is made following histopathological examination of the surgically excised mass. So parasite migrates as microfilaria into the vitreous and anterior chamber via the bloodstream into the eye and the lids and orbit, where they form as subconjunctival or subcutaneous nodules, and then it develops into adult elements, and there it ends their life. So MRI images of these adnexal worms shows a hypoechoic cyst lodging the live or dead worm with adjacent peripheral enhancing lesion. So B-scan images will show adnexal cyst worms. If it is alive, it will be seen as flickering worms, and this is what it goes by the name of dancing worm sign. So you can see the worm right in the center, this dancing worm sign. So these are intra-op adnexal lesions. So once the diagnosis is made with imaging, so the cyst can be removed. It just looks like an innocuous cyst. So I've just incised the cyst, and the worm was retrieved. This is out of interest, I've done that, and you could see it's a long worm, and the worm is alive. There was a rare case, this is diaphylaris in the medial rectus muscle. This lady presented with just a little bit of congestion, and this was the worm lodged in the medial rectus muscle. So gross pathology, the female worms is longer, which is identified with vulva at its end. Cuticle is typically multi-layered. Muscle coat is characteristically well developed. So this was the histopathology. That is the only confirmatory sign for diaphylar worm, and cyst shows inflammatory changes. So microscopic sections, it shows thick cuticle and well-developed muscle layer. So this was an interesting slide where the body cavity is filled with, of the uterus is filled with numerous microfilaria, which is not released into the bloodstream. So results, there was no gender prevalence. Here 5 cases were conjunctival and 7 were adnexal. I come from a hospital in South India, so 9 were from Kerala and 3 were from Tamil Nadu. The youngest of a patient was 12 years of age, the oldest was 62 years of age. So removal of the parasite is only treatment for ocular diaphylaris. The entire parasite must be removed in order to avoid any allergic reactions due to parasitic remnants. Antihelminthic drugs are not indicated in these cases. So in summary, diaphylaris is a vector-borne disease. Distribution infection rates have undergone significant modifications due to global climatic changes, and underreporting of cases is also noted. So this is one of our cases. So I brought this to the to show this worm. This was missed by a retina colleague, so this could be a diaphylaris. They were not as curious as me. They went in and took the worm with a vitrectomy cutter. So alarmingly increasing trend of diaphylaris infection calls for epidemiological survey, species identification, intensive studies are required, which will help in assessment of the exact prevalence of this emerging zoonotic infection and in devising appropriate control measures. So my references, thank you.
Thank you, madam, for your unexpected cases we have seen.
Thank you very much. So we just conclude this session and we just invite the next session, please.